Good morning, good afternoon, good evening. My name is Swapnil Hiremath, and I'm a nephrologist in Canada. And welcome to this edition of Adventures in Critical Appraisal for the Mumbai Nephrology Group. Thanks again to Dr. Umesh Khanna for the invitation to talk about a topic that is very close to my heart. So I don't have any disclosures for this topic. I don't have any pharma funding. I have some grants and I'm a member of some guidelines, but this has no bearing on the talk today. And I am a co-founder of NephJC, which is a Twitter-based nephrology journal club in which we do a lot of critical appraisal. And I'm a non-believer on publications, especially new drugs. So on the spectrum of being a believer, I'm more on the skeptic to a cynic side. And I often look forward to reading papers just to find faults. So the objectives of this module is to stop believing published findings at face value, to get a taste of some critical appraisal for trials, and to avoid common errors while reading and interpreting trials. And this should be a frame of mind. So this is Jonathan Swan, while he was interviewing the former President Trump, looking at the papers. It's like, you're reading a paper and you're not like, oh, wow, this is wonderful. You should be like, why? Why did the authors do this? How do they make sense? That should be a frame of mind when you're reading a paper to get the most out of the critical appraisal part. And I've written a blog, which you can read at this link on how to read a paper. And briefly, what I do like to do is to print it out. I know the trees may not be happy, but if it's a paper you're going to change your practice on, it's really important to print it out and read it very, very closely, as well as a supplement. You read the title and abstract, and it may seem superfluous, but it's really important. The abstract should be able to give you a sense of what the paper is doing, and I would read every word very, very carefully. Then you skip the introduction. You go over the methods very briefly. Look at the figures and tables, figure 1, table 1 in particular, and the main results and tables, and then you read the text of the results. And while you're reading the tables and the figures, you go back to the methods, right? At that time, you read the methods very properly. Read the supplementary appendix because it often has more methods and more results. You can read it even while you're looking at the main results. You look up the author's names, affiliations, funding body, and if at all you want to read the discussion, read the limitation section. I would say you should stop there. Don't read the introduction or the rest of the discussion unless you're really, really puzzled about some things. And they're the least helpful parts of a paper. So it's a non-linear journey, right? It's not like a highway on which you can drive and just one thing comes after the other. It's more like this, where you go back and forth and you look at this and you look at that, you consult some other paper. Don't think about reading the methods and completing all the stats and analysis before you go to the results. One of the key things, of course, before you start reading a paper is that prior knowledge is extremely important. You need to know what the topic is about, right? For example, why was the study done? What do previous studies show? Was this study really necessary? And how do you get that, right? Don't look at the introduction for that. Go find a review paper on it. If you have got access to up-to-date, read up-to-date on that topic. Look at previous trials. If you don't have access to any of these things, ask a friend or a colleague to know more about the topic, about why this trial was done. Anything else, but reading the introduction is a useful way. And this is essential. I think you have to have some background about the study, about that area before you start reading a paper, and treat the introduction like tainted material. So once you're looking at the methods, right, the one thing to think about, and I'm talking about trials here, is this even randomized? So look for the method of randomization, and some of the key red flags are if they say sequential, consecutive, alternate assignment. That sort of tells you, those kind of words in the methods mean that it was probably not a trial. It was not a randomized trial, though that may be the claim in other places. And in the methods, again, you skip the introduction. In the methods, the few things you can quickly eyeball are: you look at the study setting, you look at the primary outcomes, the inclusion exclusion criteria, anything else that stands out. But don't get bogged down in the fine details, right? You move on, just quickly look at it, and diabetes, CKD, GFR60. Okay, move on, and then come back to the finer details later. Then move on to the results. Look at all the figures and the tables first. Don't read the text. The figures and the tables should allow you to think about what the text is going to say. And the figure 1 is one of the key ones in my opinion. It's the consort figure. It has the consort figure. It tells you about the flow of patients. The table 1 is classically the baseline characteristics. The table 2 or the figure 2 have the main results. Table 3 and figure 3 may have some additional results, or they may have some adverse events and safety data. So what do I mean by figure 1? And often this figure 1 sometimes, especially NEJM nowadays, hides it in the supplement. So go find the supplement and look at the figure 1 very carefully. And this is what the consort, which is on the reporting of trials here, figure 1 should be. So, there's a box which talks about not just the patients who are enrolled, but those who are assessed for eligibility and excluded. And it's not uncommon, and this number may vary. It's not uncommon for only about 20 to 30% patients who are assessed for eligibility who get randomized. And then you look at, if whoever was eligible and randomized, did they actually get the intervention? Was the allocation complete, or were some people excluded for whatever reason? Look at the reasons for loss to follow-up, and are the numbers roughly equal in both groups? It's not unusual to have some loss to follow-up, but if one group has more loss to follow-up than the other one, that's a red flag again for seeing what is going on. And make sure that everyone who was randomized was actually included in the analysis. That's like an intention to treat analysis. Sometimes, people who get lost to follow up and this and that, you exclude a lot of people, and that's a per protocol analysis. And that's usually, it could be biased, not always, but it could be biased. So you have to keep that in mind. Some examples of figure 1. So for example, this is a figure 1 from the START AKI. As it shows here, this was figure S2. So NEJM had hidden this in the supplement. Now, START AKI was a wonderful trial. We were a site for START AKI. The results are nice, but you can always still get something from the figure 1. So what you see here, for example, is they started off with 23,728 patients, but about 11,000 patients were excluded, because even though they met the inclusion criteria, because something else, there were eligibility reasons. So potassium was more than 5.5, bicarbonate was less than 15, so on and so forth. And out of the 11,000 patients left, 11,800, about 9,000 patients were again excluded, because the nephrologist or the intensivist thought that you could not delay dialysis. This patient had to have dialysis now, or you could not do dialysis now. They were going to recover or something like that. So overall, what you see here is that, and about 3 to 4% patients were lost to follow-up, which is not at all unusual. 96, 97% is pretty good for an RCT to get in. But out of the 24,000 eligible patients, only about 3,000 were randomized, right? So that's a very small proportion who were randomized. So the lesson here is not that the trial results are not true. It's just that you cannot apply the results to any patient who has AKI in the ICU setting. So every critically ill patient who has got AKI doesn't mean you should apply START AKI, right? If their potassium is more than 5.5, if their bicarb is less than 15, or their eGFR was less than 20 to begin with, then these results don't necessarily apply. So you have to kind of think, hey, should I be applying the START AKI results to this patient or something else? So this applies most to generalizability rather than to the internal validity of the trial. This is another one, the landmark trial from Japan. This was lanthanum in chronic kidney disease. So they had about 2,400 patients, and they excluded very, very few. Almost all of them were randomized, which tells you that something is very interesting, is that, so again, of course, they had 3 to 4% loss to follow-up, but most patients who are eligible were randomized. And this may have to do something with the Japanese culture that, if you ask, patients mostly say yes. I don't know what is going on, but that's a very unusual experience to get in most of the countries. What about this European trial called LUST? So this was a lung ultrasound in hemodialysis. What's missing here is that you don't even have the number of patients who are screened or eligible. So we just don't know. That data is not available. So, how many patients were screened to get these 363 patients? We don't know. And about 10% were lost to follow-up, which is kind of highish for a dialysis population where, patients are not going anywhere. What happens to them. They are on dialysis. So despite that, about 10% were lost to follow-up, and about 3% were withdrawn. So after being randomized, after being consented, after being found to be eligible, about 3% patients, the investigator said, I don't want them to be in this trial, in both groups. So that's kind of strange things which are not completely explained in this analysis. 30% patients died. Now that may seem high, but as nephrologist, that's not at all unusual for a dialysis patient trial. Over any length of period of time, you will see that this will happen in any dialysis trial. So, for all these reasons, and I've taken just some examples. Figure 1, I think, is the most important. It tells you about generalizability. It gives you some idea about the event rate already. It tells you about loss to follow-up, especially if it's asymmetrical. and so much more. And when you see these kind of things, when you see asymmetry, when you see some concerns, then you make sure you look at the tables more carefully for those specific aspects. Again, going back and forth is completely acceptable. Now, what do I mean by table one? This is one of the most important tables, not the results, not the outcomes. Table one is really important, but do not look at it. Do not look at the intervention group and the control group and say, oh, they are well matched, or they are balanced, or they are comparable. That's not the purpose of a randomized control trial. And the p-values do not tell you whether this randomization succeeded. It was a randomized trial. You have to take the author's word for it that it was a randomized trial, right? Unless something else is a huge red flag. This is, a quote from Rajneesh Mehrotra, who's the CJSN editor-in-chief, and now to incoming JSN senior editor-in-chief, is that they don't even accept p-values for trials in that journal, in CJSN and many other good journals. So the purpose of a p-value, when you do a p-value, you're thinking of a statistical hypothesis. So what is your hypothesis here? Is it that this was not an RCT? How can that be the hypothesis of an RCT? And what happens is if you've got a small study, with 50 patients each, even if there is some imbalance, the p-value will not be significant because it's not powered to do that kind of a test. And if you've got a very large study with 10,000 patients in intervention and 10,000 in control, and you're looking at 20 variables, by chance, some of this will be different, right? The p-value will be significant just by chance. And that does not mean that randomization did not work. So the purpose of randomization is not to have two exactly similar two groups. Now, at this point, you will say, hey, Swapnil, what's going on? This is a randomized control trial. If one group is different than the other, then, how can you make an assessment of whether the intervention worked or not? Well, the purpose of randomization is to distribute the covariates randomly and not to selectively bias by having, older people in the control and younger people in the intervention or so on. This should be randomly distributed, the covariates. And that's what, whether it's exactly same or not, it's by random chance that there may be some variation. And randomization does not produce balance. And that balance, the lack of balance does not affect the validity of the analysis. So then how do you do the analysis if there is some, imbalance in the table one? Is that what you should be doing is you should be adjusting for baseline covariates. And this is a blog that explains it very nicely from Darren Daly. So it's not about balancing confounders. It's about, distributing the covariates by randomly. And what you then do is that you pre-specify in your analysis is that you're going to adjust for those covariates. You kind of say, hey, let's say we are going to adjust for age and sex and baseline GFR and diabetes status and something else. And that's what we are going to adjust for. So even if these important things are a little bit imbalanced, we are going to take care of that in adjustment. And that takes care of any imbalance that is going on. That's the right way to do it. And so the other things that you see in the table one is that it tells you about the overall population. So look at it overall, right? Not separate by group, and think about generalizability. Are these like your patients, and compare with other trials of the same intervention? So for example, what do I mean? This is a systematic review by Christos Argyropoulos and Mike Johansson. And this is the table one of all the Flozin trials that were done by about 2019. So this doesn't have, EMPA kidney and the later trials. But what you can see here, for example, is if you look at the median follow-up, the typical median follow-up was, about 2.5 to 4.2 years or so, except for two exceptions. So in the DAPA-HF and Emperor reduced, which were the two trials in heart failure with reduced ejection fraction, the follow-up period was only 1.5 years. And what was that? Why was that? Why was it so short? It was because these trials were halted early, because unfortunately in a patient population with reduced ejection fraction, you get a lot of events. These patients get hospitalized, or they die, or there is some other MACE event very often. So events will accrue very fast compared to a trial which is done in the a less selective population. Look again at the proportion of women. It's about 20 to 30%. Why does it matter? Why should we have about 50% women in every trial? Because there are 50% women in the population. More importantly, Flozins, SGLT2 inhibitors, can cause genital myocardial infection. And guess which population has more genital myocardial infections? It's women. So let's say they say, hey, 5% of your patients have genital myocardial infections. Well, in real life, it's likely to be higher, because your practice doesn't have 30% women. Your practice probably has 50% women. So take that into account when applying the results to your patient population. The ethnicity, most of these trials are done in the Western world, which are mostly in white populations. The exceptions, of course, were DAPA-CKD, which was about 50% white, and Vertis, which was, almost completely white at 90%. So again, if you have a suspicion that an intervention has a differential effect by ethnicity or race, or, there may be some social factors that matter or geography that matters, that these are important considerations. That's what a table 1 is telling you, more than balance between intervention and control. Going on, look at, for example, the hemoglobin A1C. The hemoglobin A1C in these trials was about 8%. Because they had to have, reasonably well-controlled glucose. So if your patient has a hemoglobin A1C of 10% or 12%, it's not that you cannot use a Flozin, but you are more likely perhaps to see the glycemic side effects related to increased natriuresis, because they have so much glycosuria. They may have natriuresis. You may get more volume contraction. You may get more, genital mycotic infections, because there's all this sugar coming out into the urine and so on and so forth. So be careful in extrapolation. The duration of diabetes in most of these studies was about 10 years, if not longer. And these were not patients with incident diabetes. Again, doesn't mean you should not use these drugs in incident diabetes, just that you have to be careful while extrapolating these results. And you can see an outlier there in that canvas, which was the trial which reported the more peripheral, amputations and fractures. A lot of those patients, by chance, had peripheral arterial disease. So keep that in mind when you see some outlier when you're comparing trials. There are many more things, right? I'm just showing some high points about what you should be looking at when you're looking at a table 1. What about subgroup results, right? So what if the overall study result is negative, but it looks like in one subgroup, oh, it seems to work in this one subgroup, or vice versa. When you have a result that is overall positive, the intervention works, finerenone reduces kidney failure, but then you look at all subgroups, some of those subgroups are negative. Does it mean you should not use finerenone in those subgroups? Well, a trial is powered for the main outcome in all patients. So what it means, it will be underpowered for subgroups. If you've got 1,000 patients, but not all of them are men. So if you look at men and women, 500, 500, or 800, 200, well, maybe in the 200 women, you may not even have enough power to show that the drug is working. So by chance, the 95% intervals will cross 1. So don't look at that and think that, oh, this drug doesn't work in women. That will be completely wrong. This is like a brilliant example where the drug worked in everything. But this is a Flozin, right? Dapagliflozin in chronic kidney disease. This is all of them line up on this side of 1. It's a wonderful drug. It works for everybody, but this is an exception. What you're more likely to see something like this, where you see that line, and you can see some subgroups are on this side of the line, but many subgroups cross over. And it doesn't mean that the drug doesn't work in that patient population, right? If you look here, for example, in the region, Europe, North America, Latin America, others, they all cross 1. It only seems to work in Asia. Does that mean you will not use finerenone if you are not in Asia? No, that would be ridiculous. Another example here is that if you look at the SGLT2 inhibitor subgroup, there were about 250 patients who were on an SGLT2 inhibitor, and that in those, this is the kind of a result. But there were only, about 24 events. So 24 events in 250 patients, it doesn't tell you with any degree of confidence whether finerenone works in patients who are on SGLT2 inhibitor or not. And you can see that with the Figaro trial, which came out later. And because by that time, Flozins had been well accepted, they had about 600 patients who were on Flozins, and they got about 60 events. So 60 events, which is way more than 24, they got a sufficient degree of confidence that they could say, hey, these drugs seem to work whether you are on a Flozin or not. So that's sort of the key, something to keep in mind, is that you interpret subgroups very, very carefully. And it's okay to ignore them because they're mostly random error and chance, and you can consider them as hypothesis generating at best. The p-values for interaction, some journals will publish them. They're somewhat useful, but you cannot rely on them completely. What about adverse events? So adverse events in trials, table 3 or table 4 sometimes, they may not reflect real life experience, right? I mentioned genital mycotic infections. With the hemoglobin A1C of 8, you may see different level of genital mycotic infections in 30% women than what you may see in real life, where your hemoglobin A1C may be 9 or 10 or 11, and you may have 50% women. And these are carefully chosen patients, so they are often healthier than your general population or your patient. So you may see less side effects. On the other hand, they may have more careful monitoring. Maybe the potassium level is being checked often. Maybe the creatinine is being checked often. So there's more AKI, more hyperkalemia, which may or may not be clinically significant just because there is more diligent monitoring. So it can be a mixed effect. So you have to take that, interpret it accordingly. There is no, simple rule for saying adverse events are more or less. For example, this is again the Fidelio trial in diabetic kidney disease with finerenone, where they said few patients discontinued finerenone due to hyperkalemia. Well, if you drill down into the supplement, what you can see is that there were 120 more patients on potassium binders. At baseline it was 70, and it went up to 307 in the finerenone group and 66 to 184 in the placebo. So overall, there were about 120 patients more on finerenone who were on K binders. Why were they on K binders? But there must have been some hyperkalemia, obviously, right? So that's why they were given finerenone. And if you look at the investigator-reported hyperkalemia, it was about 250 patients more. About 32 patients more had serious hyperkalemia. So this is hyperkalemia which is serious enough to go to the intensive care unit or to go into to the hospital or get hospitalized, or visit the emergency room. So that again tells you that hyperkalemia was way more important than what the authors are trying to say, that hardly anyone discontinued it. Well, they didn't discontinue it because it was treated medically. Something had to be done. Maybe they got binders, maybe they went to the hospital and other things were done to fix the potassium. Maybe the ACE inhibitor was stopped, who knows? And that number is more than the number of 20 patients who did not develop end-stage kidney disease, right? So I'm not saying finerenone doesn't work, it works, but there is hyperkalemia that you have to take care of when you are dealing with this drug. So look beyond the the top line adverse effect. Everything is fine, the result that the authors may try to portray. And again, look at the figure 1. So this was the study design where they had an extended run-in and screening period. The purpose of this run-in and screening period was to exclude patients who were at high risk of hyperkalemia. Well, then you should be looking at the figure 1 to see how many were excluded for hyperkalemia. That number is not provided to us. We have no idea how many were excluded because of hyperkalemia. So if you apply this finerenone to your general patient with diabetic kidney disease, maybe they will develop hyperkalemia right away, and those kind of patients were excluded in the trial. So that kind of information would have been useful to have for you to know that, hey, maybe half the patients are going to develop hyperkalemia, so then you will be on the lookout. But if it's 10%, you will be like, it's a much smaller number. But if it's 80% who develop hyperkalemia in the run-in screening period, then you are going to be much more careful and meticulous about measuring potassium. And there's much more to know. There's actual statistical analysis, there are effect estimates, survival curves, there are newer Bayesian and adaptive study designs. That's way more than I can always talk. But the main important thing with how to learn critical appraisal is that it requires a lot of time. You need to practice and you need to learn from others. There is no course that you should take or anything like that, which is going to tell you how to do critical appraisal. A couple of small examples. This was a trial done from Italy on cevilamor versus placebo in patients with CKD who were not on dialysis. And it was about 200 patients, and they showed that not only was there a mortality benefit with cevilamor, but it also lowered the need for dialysis, right? So every patient with CKD should be getting cevilamor because you are less likely to die and less likely to start dialysis. What's the hesitation? Well, what you see in that figure 1 is that they don't even give you any numbers about screened or eligible. But then if patients had a poor quality basal CT scan, they were excluded. But coronary CT was not an outcome. So why were the patients excluded if coronary CT wasn't good? Which makes me think that, it was a feasibility study and that coronary CT was an outcome, but then they switched it later on. And if you look at their survival curve for mortality and dialysis inception, and you add the numbers, what you can see is that all the patients are included in the mortality as well as the dialysis inception, which means that the patients who died were still included as being at risk for starting dialysis. Now, I don't know about Italy, but in most other countries, if you die, you cannot start them on dialysis. You cannot be at risk for starting dialysis because you're dead. So I'm not sure what kind of statistical package or calculation was used to make up this graph. And if you look at this one, for example, in the first 12 months, there are no events at all. So no one died and no one started on dialysis. This is also very strange. This doesn't happen in real life. Patients start dialysis or die all the time, especially if they've got stage 3 or stage 4 CKD. So it's kind of an immortal time bias that was cooked in, perhaps because of the way things were measured or done. This does not happen in a real RCT. There were other issues, right? The trial protocol was not registered. They call it a pilot trial, in which we usually look at feasibility of enrollment or surrogate outcomes. And they report clinical efficacy outcomes. The primary outcome was mortality, but death after dialysis initiation. So they said if you start a dialysis, we are not going to count if you die or you don't die. Though they were following up with those patients. That's like, oh, why? Your primary outcome was not dialysis; it was mortality. And patients who did not have coronary artery calcium data were excluded. There was another study they did, which was published a year later, in patients who were on incident hemodialysis. Again, similar thing, sevelamer versus calcium carbonate. And what they showed here is that their primary outcome was not mortality. It wasn't cardiovascular mortality. It was cardiovascular mortality due to cardiac arrhythmias. A very, very strange, unique primary outcome, which I've never seen again in a dialysis study. And you're not talking about a drug which is an antiarrhythmic, right? This is sevelamer. And the relative risk was 0.06. So there was a 94% relative risk reduction in death due to cardiac arrhythmia. So if you give sevelamer, you're not going to have any arrhythmia almost, right? You are going to be immune to getting any arrhythmias. Wonderful result. But actually, if you look at the clinical trials, which and this was done in a letter to the editor, is that they changed after the paper was submitted to AJKD. They went back and they changed the outcome from death to cardiac arrhythmia as a death, and they all switched it. Perhaps because they saw the results and they said, "Oh, let's change what we are trying to do." So clinical trials registry are also a useful tool to look for history of changes. And genuine fraud is hard to detect, right? This was in the nephrology field. So this was a Canadian researcher who looked at bone stuff, and the studies that she published in JAMA and other journals were actually retracted. This is unusual, and if you read what is covered in the retraction watch, they actually found evidence that she looked at patient records, she changed computer files, and she went into the freezer and damaged some samples so that the audit couldn't be done properly. She was actually let go from the university for that reason. But if you look at the KDIGO guidelines, they have this guideline saying you should do bone mineral densitometry in patients with CKD. What does it rely upon? It relies on this study, which was authored by Dr. Jamal, which has actually been retracted. And if you look at all the KDIGO CKD MBD guidelines, they have about 7 direct citations to her work, which support 3 recommendations. They're still there. Papers been retracted, the guidelines haven't changed, right? So, in my opinion, this topic is terrible. If you look at the mineral bone disease and chronic kidney disease, it's an easy topic to criticize. It's like shooting fish in a barrel, because there is observational literature with tons of confounding and selection bias. And even the trials are like that DIREO trial I'm showing, which is terrible, right? You can easily poke holes in that. These are a couple of blogs that I've written if you're more interested in the topic, which goes into it in a more fun and entertaining way. There's always more, right? I do mostly hypertension. And a few years ago, this came on BBC and CNN saying, you should change the time of day, right? This one simple thing reduces your risk of dying of 45% and many other outcomes. This was published in a really premier journal, the European Heart Journal, in 2019. Now, these are the guys who got the Nobel Prize for circadian rhythm, and circadian rhythm is really important. There is no question. Nocturnal dipping is very important, and if there is no nocturnal dipping, we know that with nocturnal hypertension, the risk is about 1.4, 1.5, so about 40 to 50% higher risk of having cardiovascular outcomes. Now, what that means is if you take away that nocturnal hypertension, you should get that much of a reciprocal improvement, which will be about 0.67. On the other hand, what these authors found was like 0.55, which is even more than what. So the benefit from giving pills at night was more than the harm that is caused by nocturnal hypertension, which does not make any sense. And the non-dipping pattern is seen for various reasons, right? Maybe a patient has obstructive sleep apnea, maybe they have CKD and volume overload, maybe they have increased sympathetic activity, maybe they have diabetes or some other sleep disorders. So it's a complex phenotype, right? If you just take amlodipine at night, how is it going to fix that sleep apnea or that increased sympathetic activity or the patient's volume overload? It's not going to fix it. So how can it reverse this phenotype just taking the pills at night? And this is sort of a meta-analysis which looked at time of day use and outcomes. And what this shows that, yes, it does matter what time of the day you take a drug if it's a short-acting drug. So in hypertension, this matters for hydralazine or captopril, which are short-acting drugs which no one should be using. In the modern era, we use longer-acting drugs like say amlodipine or telmisartan or perindopril. And for that, time of day should not matter whether you take in the morning or afternoon or night. If you look at the figure 1 for this Hygeia trial, what you see is that, there was zero loss to follow-up, like not even 1% or 2% loss, right? This is bigger than the Japanese trial where I showed most patients were enrolled. Like no one was lost to follow-up for a single center trial, which is like wonderful. 20,000 patients. We should learn from them how to conduct trials and not have patients lost to follow-up. Now, what they show here is that not only was there a decrease in cardiovascular death, so 310 patients, but also overall death, which is 957. Now, if you look at those numbers, if overall deaths were 957 and 310 were cardiovascular deaths, that means about 650 were non-cardiovascular deaths, which lets you, look back at the numbers and calculate that even for non-cardiovascular deaths, the hazard ratio would be about 0.6. Now, what do I mean by non-cardiovascular deaths, right? So non-cardiovascular deaths usually refers to that because of cancer, because of infections, because of trauma. So not only does giving blood pressure pills at night reduce your death from heart attacks, but it also reduces your death from cancer. So, if you give amlodipine at night and your patient will suddenly not die because of cancer or they will not have an accident, which is again wonderful if you believe it. And not only that, it reduces uric acid. Giving perindopril at night will reduce your will increase your HDL cholesterol, reduce your LDL cholesterol. All sorts of magical things start happening. And if you look at adverse effects, right, the adherence was perfect. This is all they show you. There is no table of adverse events. And what you would expect is, that adherence would not be the same. What you see this is a study from the BMJ, which shows that when you take drugs in the morning, then that has the best adherence. If you take drugs in the evening, that has about 5 to 10% lower adherence, which is common. Most people take their pills in the morning. To ask them to take their pills at the night, the adherence is going to drop. However, in Spain, in Hygeia, it was the opposite, is that patients were wonderful. They took their drugs perfectly. And you normally, if you have any intervention which lowers blood pressure, you are more likely to get adverse events related to hypotension. So if you're giving pills at night and you believe that it's going to lower the blood pressure at night, you should have lower blood pressure at night, which will do some other bad things. For example, there is subendocardial ischemia because of the hypotension. Maybe there will be low blood pressure in your eyes, leading to central retinal artery occlusion. Now, forget about having a higher risk of side effects. They actually report that the risk of those side effects was lower by giving blood pressure pills at night, which is amazing, right? This is just amazing. Now, you may think, Swapnil doesn't believe in any studies and he's poking holes in that. Well, this was the TIME trial done out of UK, which was published last year. Very similar thing, looking at, morning versus evening bedtime dosing of blood pressure pills. And what they showed is that there was exactly no difference. This was much larger, way more rigorous, and this is way more believable data that, it doesn't matter whether you take pills in the morning or night. So my suggestions on critical appraisal is that you need to have a very antagonistic frame of mind. Usually only one author, possibly an editor, and 2 reviewers have read the paper carefully. So, don't believe that because it's published, a lot of people have read it. Often no one will have read it, just the author and one or 2 reviewers who may have, missed the mistakes. Try to find flaws. You read the supplement, pour over figures and tables, and do not read the introduction or the discussion. Now, even if there are some flaws, it may be that the study is still acceptable, right? Even if I can poke holes, doesn't mean you have to throw out the baby with the bathwater. It may still mean that, it's still, you should still practice the change that the trial is showing, except with some caveats about, say generalizability or what have you, or look for more adverse events than what you would see in the trial. And this is like a famous paper from J.P. Anadis from Stanford, who talked about, why most published research findings are false. And this statement is in fact very, very true by papers from the same author who has published a bunch of garbage during COVID. So, just some Q&As, and I'm not asking you these questions, but, the most important steps I hope you have learned in learning critical appraisal is to read every paper with a close skeptical eye. You don't need to do a course in stats. You don't need to attend a lecture. You just read every paper very closely, go back and forth and try to understand it to be able to do a proper critical appraisal. There is no correct order for reading a paper. Go back and forth, read methods, read results, go back, read the abstract, read the supplement, then read the results. It's completely fine. You should not finish understanding the stats before you read the results. And in my opinion, table 1 does not tell you whether randomization worked. Do not look at a subgroup analysis. Do not read the discussion. The figures and tables are the most important aspect. The figure 1 is, I think, the most important figure in the paper, more than the survival analysis or some bar graph of effect size. So with that, I'd like to stop. Thank you for this invitation from Dr. Khanna again. If anyone has any questions, you can contact me on Twitter or Mastodon, or my email is up there. I hope you know about NEFJC, which is a journal club we run on Twitter. If you're not a Twitter or a blog person, we also have a podcast called Freely Filtered. The most important thing, of course, if you want to know more about this, these are some suggestions for people to follow. Perry Wilson from Yale has a really nice blog on a YouTube series if you like watching videos like this. The most important thing, of course, is you should be a flozinator, right? Flozins are the most important drugs we will see in our lifetime. They reduce kidney failure by about 40%, heart failure by 40%, all-cause mortality. Every patient you see in the nephrology clinic, think about, can you, are they candidates to have a SGLT2 inhibitor or a flozin? Thank you.